Managing myelofibrosis in 2019 is evolving very quickly. We've had the approval of Ruxolitinib now for many years, and we've learned key things about the use of this agent. One, it's very helpful. Two, we've learned that using an adequate dose is probably important to optimizing long-term impact. So if there's probably an unmet need, I think there is a lot of underdosing of Ruxolitinib which occurs. Second, stem cell transplantation continues to be the main curative therapy for myelofibrosis. Although we use it in the minority of patients, we have learned that delaying transplant and using it solely as a salvage therapy is probably suboptimal. It's really probably best to transplant patients with myelofibrosis when they're having an optimal Ruxolitinib response, particularly if they're intermediate to and high risk. Third, we now have approval in the US and likely soon to follow in the UK and Europe, elsewhere, the approval of Fedratinib. So Fedratinib is an additional JAK2 inhibitor. It's now the second agent approved for myelofibrosis and is approved with a fairly broad indication in the US based on the positive results from the Jakarta and the Jakarta 2 studies.